That time of year when a little one gets a sniffle and suddenly it's this awful cough and they're working so hard just to breathe. It's such a common worry for parents.
It really is.
And today we're going deep into one of the most frequent reasons behind that bronchiolitis.
Exactly. Bronchiolitis is something we see an awful lot of, especially in the colder months. Put simply, it's an acute infection, hits the lower respiratory tract.
Lower tract, okay.
Yeah, causing inflammation and swelling in those really small airways in the lungs, the bronchioles. Affects infants and young kids primarily.
Right, bronchiolitis. Let's make sure we really get our heads around this for revision. We've got some notes here, basically revision guides promising the key info. So our mission today is to pull out all those crucial bits about bronchiolitis, really solidify that knowledge for you.
Absolutely. And the first thing is nailing that definition. Like we said, inflammation, swelling.
Yeah.
Bronchioles, those tiny passages.
And the main cause, the usual suspect, it's generally a virus, isn't it? Respiratory Syncytial Virus, RSV.
Spot on. RSV is the #1 cause in, well, the vast majority of cases. And it's important to remember, doctors diagnose this clinically.
Clinically. So based on what they see and hear?
Exactly. The symptoms, the signs on examination. And look, most times it's self-limiting. It gets better on its own with good supportive care.
Supportive care, definitely need to unpack what that means, but you mentioned definitions can vary a bit. Why does that matter?
Well, that little bit of variation, it can actually make a difference when you're looking at clinical trials, for example.
I see.
If studies define bronchiolitis slightly differently, it just makes it harder to compare their results directly,
Yeah,
to be certain about what works best.
that makes total sense. Okay, so we know what it is, who it affects the little ones. Now why? What actually causes it? The etiology.
Right. So the main driver, as we've established, is a viral infection. And RSV really dominates maybe 75 to 80% of cases.
Okay, the big one.
But it's not the only player. You got other viruses too. Rhinovirus, that's your common cold virus.
Right.
Adenovirus, influenza, human metapneumovirus or HMPV, and Parainfluenza viruses. They can all trigger it too.
So a whole range of viruses, even if RSV is the most common. How do these actually spread child to child?
Primarily through respiratory droplets. So an infected child coughs or sneezes, and those tiny virus-filled droplets get inhaled. Or to contaminated surfaces.
Ah, touching things.
Yeah. Kid touches a toy with a virus, then touches their mouth, nose, eyes.
Yeah.
And that's it. Infection starts.
Simple contact. Wow. Can a child get more than one virus at once, like a co-infection?
Yes, definitely. Co-infection can happen.
Yeah.
And there's also a risk, though it's less common, of getting a secondary bacterial infection on top of the virus.
Okay.
And it's also really important to know that kids with certain underlying health issues can get much sicker with bronchiolitis.
Right. So that leads us perfectly into risk factors. Who's most likely to get it? And maybe more importantly, who's likely to get a severe case? Let's break those down.
Yeah, thinking about them in categories can help for revision. So first off, age. That's a huge one. Kids under 2 are most susceptible.
Under 2.
And it's particularly common in that first year of life.
Makes sense. Tiny airways, developing immune systems. What about their surroundings, environmental factors?
Definitely. Tobacco smoke exposure is a big one.
Yeah.
Especially maternal smoking during pregnancy or secondhand smoke after birth.
Okay.
Also, crowded living conditions, having older siblings, bringing bugs home from school.
Yeah.
And attending nursery or daycare themselves. More exposure, basically.
More bugs, more risk.
Got it. Anything about their birth history?
Yes, being born prematurely, that's a significant risk factor. And having a low birth weight, too. Their lungs might not be fully developed.
Okay, prematurity and low birth weight.
Yeah.
And what about existing health problems?
Absolutely. A whole list of underlying conditions can increase the risk of getting it and of it being severe. Things like chronic lung disease, congenital heart problems.
Neurological diseases, epilepsy, a weakened immune system, problems they were born with in their airways, like congenital airway defects, and Down syndrome, too.
That is quite a list. Is there anything that might actually help protect them?
Yes. There is evidence that breastfeeding offers some protection. Breast milk has antibodies that help fight infection.
That's good to know. So just to really hammer it home, what are the key things that point towards a higher risk of severe bronchiolitis?
Okay, for severe disease, the big ones are prematurity, low birth weight, needing ventilation as a newborn, being very young, especially under 12 weeks old,
right,
having those underlying conditions we just listed, and Down syndrome is also a specific risk factor for severity.
Okay, super clear. So we know who's at risk.
Huh.
Now, let's get into what's actually happening inside the body, the pathophysiology. What's going on in those little lungs?
So it starts with the virus infecting the cells lining the airways, the respiratory epithelial cells. This infection triggers inflammation in the walls of the bronchioles. And this inflammation, plus the body making more mucus in response,
Right.
it leads to those small airways getting narrower and obstructed, blocked up.
So they get inflamed and clogged. How does that cause the symptoms we actually see, like the cough and the wheeze?
Well, exactly. If the airways are narrowed and blocked, it's just harder for air to get in and out. Simple as that.
Okay.
And that leads to the coughing, the wheezing sound, that high-pitched whistle, and the difficulty breathing, often seen as breathing faster, working harder.
And if that blockage gets really bad, what happens then?
In severe cases, yeah, the obstruction can be so bad that not enough oxygen gets into the blood.
Yeah.
So blood oxygen levels drop. That's called hypoxia.
Hypoxia. Serious stuff.
Yeah, that needs very close monitoring.
Yeah, absolutely. Now, bronchiolitis isn't the only thing that makes babies cough and wheeze. What else could it be? The differential diagnosis?
Yeah, this is really important for clinicians. A very common mimic is something called viral-induced wheeze.
Okay, how's that different?
Key differences might be you don't hear crackles when listening to the chest. Maybe the child's had wheezing episodes before, or perhaps they have a background of atopy things like eczema or allergies.
Okay, so maybe more episodic, linked to allergies, perhaps. What else?
Pneumonia, that's a big one to rule out. Red flags for pneumonia would be a really high fever, say over 39 degrees Celsius, and hearing persistent crackles just in one area of the chest.
Vocal crackles. Got it.
Then you've got asthma, obviously, bronchitis, even pulmonary edema, which is fluid on the lungs, though less common in this age group, without underlying issues.
And some rarer things, perhaps.
You always have to think about, did they inhale something? Foreign body aspiration, especially if the symptoms came on really suddenly.
Good point.
Esophageal reflux, where stomach contents come back up, or aspiration pneumonia from inhaling food or liquid. You'd look for feeding issues there. And then much rarer things like cystic fibrosis, check family history, other signs, or Cardiganer syndrome.
Cardiganer, cytosine versus right, organs, MERD.
Exactly. And things like tracheomalacia or bronchomalacia, floppy airways, basically, they might have stridor, that noisy breathing sound. And finally, a pneumothorax, a collapsed lung. Sudden onset, usually signs on just one side.
Wow, it really shows why taking a detailed history and doing a careful exam is so vital.
Absolutely critical. The overall clinical picture guides the diagnosis.
Okay, let's zoom out again. Epidemiology. Who gets this? When does it happen?
As we've said, mainly infants and young children. The peak incidence, the highest number of cases, is in that first year of life, especially between 3 and 6 months old.
3 to 6 months. And how common is it overall?
Very common. Estimates suggest maybe a third of all babies get bronchiolitis before they're 1 year old.
A third. Wow.
Yeah. And about 2 to 3% of those end up needing hospital treatment. The numbers are big in England. Back in 2019-20, there were over 47,000 hospital admissions for it.
47,000. That's huge pressure on the system. Is there a specific season for it?
Oh, yes. Classic winter illness. Peaks between October and March, usually. Yeah. And within that season, you tend to get these sort of annual surges lasting about 6 to 8 weeks.
Right, the winter surge. But I remember something unusual happening a couple of years ago, summer cases.
That's right. 2021 saw this really weird summertime surge. The thinking is, because of all the COVID-19 restrictions the previous winter.
Lockdown effects.
Exactly. Less RSV circulated.
Yeah.
So you had this larger pool of infants who hadn't been exposed yet, low immunity, and bang, it hit them in the summer when things opened up.
Fascinating knock-on effect. Okay, so we know when it hits. What does it actually look like? The clinical features, how does it typically present?
It often kicks off like a standard cold. Runny nose, maybe a bit stuffy. Then the cough starts.
Just a cough at first.
Yeah, then it progresses. You might hear wheezing, that high-pitched sound. Breathing gets faster, tachypnoea. Feeding often becomes difficult because breathing is hard work. There might be a fever, but usually it's not super high, generally under 39 degrees Celsius.
And what signs might a doctor or nurse pick up on examination, things to look for?
Signs of increased work of breathing are key. You look for retractions, see the skin pulling in between the ribs or under the rib cage or the neck.
Yeah, sucking in.
Exactly. That shows they're using extra muscles to breathe. And in severe cases, cyanosis, that bluish tinge around the lips or on the skin, that's a sign of low oxygen hypoxia.
Okay, so history plus exam findings. Are there specific criteria like from NICE to help diagnose it?
Yes, NICE guidelines are really helpful here, especially for kids under 2. They look for that 1 to 3 day history of coryzal symptoms, the runny nose stuff, plus a persistent cough, and either rapid breathing, tachypnoea, or chest recession, retractions, or both. And then either wheeze or crackles on listening to the chest, or both, plus usually that fever under 39 and often poor feeding.
That's a useful checklist. Now, what about in primary care? When should a GP refer a child to hospital? Oxygen levels are key here, right?
Yeah, absolutely crucial. Measuring oxygen saturation, SpO2, is vital. Referral to secondary care, so hospital, is needed if the respiratory rate is consistently over 60 breaths a minute.
Okay, over 60.
Or if there are signs of dehydration, or they're not taking enough fluid, say less than 50–75% of usual. Also, if the baby is under 3 months old or was premature or has significant underlying health issues.
And what counts as an emergency? Immediate referral.
Right. Immediate 999 ambulance referral if there's apnea episodes where they stop breathing, or severe respiratory distress things like grunting sounds, really marked recessions, respiratory rate over 70. Central cyanosis is an emergency. Oxygen sats persistently below 92%. Or if the child just looks seriously unwell to the clinician.
Okay, clear red flags. And are there consider referral situations? Not quite emergency, but needing assessment.
Yes. Consider referring if the respiratory rate stays above 60, if feeding is significantly reduced. Say they're taking maybe 50–75% of normal volume, if there's clinical dehydration, if SATs are persistently a bit low, say under 92%, even if it's not an emergency, or if they have those known risk factors for severe disease we talked about earlier.
So the typical illness sort of progresses through stages.
Yeah, usually. Starts with those cold symptoms, maybe a slight fever. Then the dry cough kicks in. Then breathing gets faster, more effortful. Wheezing often starts then. Crackles aren't always there. And it's often the breathing difficulty interfering with feeding that becomes the main reason for needing hospital admission.
Okay, so doctor suspects bronchiolitis from the clinical picture. What about tests? Are investigations routine?
Diagnosis is really primarily clinical, based on the story and the examination. But pulse oximetry, checking oxygen levels, that's pretty much standard practice, a key initial check.
Okay, SATs check. What about identifying the actual virus? Swabs.
Yeah, viral swabs, usually a throat swab or a nasopharyngeal aspirate, a sample from the back of the nose. They're often done in hospital, mainly to detect RSV or other viruses. Helps with infection control, too.
When would you do more tests, like bloods or x-rays?
Usually only if the child seems to be getting worse, or if they develop a really high fever over 39 degrees, remember? Or if listening to the chest suggests something specific in one area, like pneumonia, perhaps.
So for typical bronchiolitis, chest x-rays, blood tests, blood gases, generally not needed.
Exactly. They're not routine. You'd consider them if you're worried about a complication or thinking maybe it's not bronchiolitis after all. And just to mention that specific test, immunofluorescence on the nasal secretions, that can directly detect RSV.
Okay, so management is mainly supportive care. What does that actually involve day-to-day for a child with bronchiolitis?
Supportive care is the absolute cornerstone. Hydration is number one, making sure they get enough fluids. So monitoring intake is vital.
Right.
Monitoring oxygen levels, the SpO2, also key. If SATs are persistently low, usually below 92%, then supplemental oxygen is given, often via head box or a nasal cannulae for babies.
And all that snotty congestion, how do you deal with that?
Nasal suctioning can be really helpful, sometimes preceded by saline drops or spray to loosen the mucus. Clearing the nose makes a big difference to breathing, especially for young babies who mostly breathe through their nose.
Makes sense. And if they can't feed because they're breathless?
If oral intake is really poor, then nasogastric tube feeding and G feeding might be needed. A tiny tube through the nose into the stomach ensures they get nutrition and hydration.
Okay. Now, the big question parents often ask medications. What about inhalers, steroids?
Yeah, it's a common question. But generally, based on evidence, medications are not routinely recommended for bronchiolitis.
Not recommended. Why not?
Well, bronchodilators like salbutamol inhalers, they haven't consistently shown significant benefit in most bronchiolitis cases.
Yeah.
Same for corticosteroids like prednisolone. The evidence just isn't strong enough to support routine use. Nebulized adrenaline has been looked at, but often doesn't perform much better than just nebulized saline.
What about antibiotics?
Very limited role. Remember, bronchiolitis is viral. Antibiotics only come into play if there's a strong suspicion of a secondary bacterial infection.
Okay.
And other things like montelukast or the antiviral ribavirin, again, not shown to be beneficial for typical bronchiolitis.
So it really is about supporting the child while their own body fights the virus off. Is there anything else sometimes used? hypertonic saline, chest physio?
Good question. There's some evidence that nebulized hypertonic saline, that's salty water, basically, but saltier than normal saline, might slightly reduce how long kids stay in hospital or how severe it gets for some. But it's not used everywhere. Practice varies. And chest physiotherapy may be considered in specific cases, perhaps if there are associated conditions or lots of secretions. But again, not routine for all.
Got it. When does a child actually need to be admitted to hospital? What are the NICE criteria?
Okay, NICE says admission is needed for apnea, stopping breathing, not taking enough fluids leading to dehydration, signs of severe respiratory distress we talked about, or persistently low oxygen sats.
Low sats meaning?
Below 90% if they're 6 weeks or older, or below 92% if they're younger than 6 weeks or have underlying health conditions.
Okay. And when are they ready to go home? Discharge criteria.
They need to be clinically stable, taking enough fluids by mouth again, and keeping their oxygen sats consistently above those thresholds for at least 4 hours, importantly, including while they're asleep.
4 hours stable, including sleep.
Yeah.
Okay. So overall, what's the outlook, the prognosis?
Generally, it's very good. Most children recover fully, usually within 1 or 2 weeks. But as we've stressed, it can be more severe for those high-risk groups, kids with chronic lung disease, babies under 3 months, very premature babies.
And unfortunately, it can sometimes be extremely serious.
Yes, sadly. While rare, deaths do happen. In England, it's around 70 deaths a year linked to bronchiolitis, mostly in very young infants, under 6 months, or those with serious underlying heart or lung problems.
A sobering statistic. Does this mean prevention is really important? What can be done?
Prevention is key, especially for high-risk infants. Immunoprophylaxis exists. Historically, RSV immunoglobulin, or palivizumab, that's a monoclonal antibody given as monthly injections through the RSV season.
Palivizumab, okay.
More recently, nirmatrelvimab, another monoclonal antibody, offers protection with just a single dose for the season. It's being rolled out more widely now for infants in their first RSV season in some places.
Nirmatrelvimab, that sounds like a big step.
It potentially is. And of course, basic infection control remains vital. Hand washing, PPE in hospitals, isolating infected individuals, all helps reduce spread.
Good old hand washing. Finally, complications. What are the main risks if things go wrong?
The most serious is respiratory failure, needing ventilation support. Secondary bacterial infections, like pneumonia, can happen. And as mentioned, very rarely, death. The risk is higher for those infants with pre-existing health problems.
So it really underlines the need for good monitoring, supportive care, knowing when to intervene, and those preventative strategies where possible.
Absolutely. Awareness and appropriate timely care are crucial, especially for the most vulnerable babies.
Okay, so let's pull this all together for revision. Your key takeaways for bronchiolitis. Remember the mnemonic bird. Bronchioles inflamed, usually by RSV, causing increased mucus and difficulty breathing. Management. Supportive.
Nicely summarized.
Yeah.
And just a final thought for you to consider as you revise. With these newer preventative measures like nirmatrelvimab becoming more common, how might that change the whole landscape of winter pressures from bronchiolitis on pediatric services in the years ahead?
That's a really interesting point, something definitely worth thinking about. Okay, for everyone listening and revising for the MSRA, keep going. You absolutely can do this.
You can.
And don't forget to check out pastthemsra.com and PREMIESSRA.com for more brilliant revision resources that really are invaluable.
Great resources.
Until our next deep dive.